what we're seeing now is a lot of new biologicals and other treatment modalities that are coming along that we are faced to use in our practices. And some of these are new to the allergists, although we are trained in immunology, and I think it's in our wheelhouse. So the incorporating these and finding the patients who would benefit is going to be very important. One of the big challenges we have is, even once we identify those patients, is having the payer coverage for these treatments, in that they're often niche type treatments. We now talk about personalized medicine, and there's still a tendency for the payers to look at, they like to lump more than split. And so as we identify patients who would benefit, getting through the hoops we need to get through to get these different treatment modalities covered. Well, it's actually various ones. We have a couple new immunotherapy oral tablets available now for seasonal allergies, very specific for grass allergy and ragweed allergy, for allergic rhinitis. We have a variety of new treatments that are becoming available in the near future for chronic, more difficult to treat asthma. And these are what I refer to as the biologicals, and that those treatments could be game changers for our patients, but they're very specific for different, we call phenotypes of asthma. And as we look at those phenotypes and are able to categorize our patients more by biomarkers, we should be able to have these treatments available. And again, we're hearing, even though some of these are not even on the market yet, that there could be a considerable pushback from the payers and being willing to pay for these treatments, because they are expensive, yet they're cost effective if you look at it from a standpoint of care for that more severe asthmatic patient. Well, there's a couple of ways you can do it. I mean, as more studies are being done and we have good clinical outcomes, that's one important method, obviously, that they hopefully will look at. I think another would be modeling socioeconomic benefit to both the payers and the patients, because oftentimes if you're not treating these patients, they can be very expensive patients for the payer. One of the challenges we have is a lot of these are the way the managed care companies in particular are set up. They're siloed, so you may have a pharmacy benefit over on one side and a benefit on hospitalization on another, but the two don't necessarily talk to one another, and because of that, it sometimes makes it difficult to get this coverage. I think we'll get through it. Just it's going to be a challenge. We're able to stratify more. Some of the syndromes, like asthma, is really a syndrome where it's not the same in individuals, so we're able to identify those. But I think there are some new emerging conditions. One is eosinophilic esophagitis, which is a type of problem with the esophagus that is seen in allergic patients. Of course, a lot of the prior immunodeficiency syndromes have been, as we have more research, we're able to stratify those better. So a lot of time it's more stratification, and also recognizing maybe emerging allergens that we didn't know about before. Just in recent years, we've recognized in the last 20, 25 years things like cockroach and mouse and those kind of things that can cause allergies. So we're also learning more and more about the allergens themselves. For instance, dust mites. We now know there's several identifiable allergens in a dust mite. It's not just one thing causing the problem.